you everyone for joining us today. Despite the loud Blue Angels going by the medical center, hopefully you'll still be able to hear us. I'm really excited to introduce our speaker. Carolyn Sloan is an assistant professor of medicine and general internal medicine at Duke University. She completed medical school at the University of Pennsylvania and her internal medicine residency, chief residency, and general internal medicine fellowship at Duke University. Her clinical interests are in primary care for vulnerable and historically underserved populations. Her research interests focus on the role that money plays in medical decision-making for middle-aged and older patients with multimorbidity. She has studied the impact of Medicare payment reform on the way dialysis facilities provide care to patients with end-stage renal disease. And more recently, she has evaluated the ways that doctors and patients communicate about and make decisions based on out-of-pocket costs. So thanks so much for joining us today, and I will let you take over.
All right, so thank you for that introduction. And I don't know if this is possible or what the format exactly is, but I'm happy to get interrupted at any time if there's clarification needed throughout the talk. So I will get started. And just to make sure you see my slides, not my preview thing. Okay. So in my talk, here's a little outline. I'm going to give you some background on the burden of high out-of-pocket costs for patients who have multiple chronic conditions. Then I'll describe a study that I led showing how hard it is for clinicians and patients to actually estimate out-of-pocket costs at the point of care. There may or may not be a pop quiz. Third, I will describe new efforts at the federal and health system levels to improve out-of-pocket cost transparency for patients. And then finally, in the last part of the talk, I'll provide some suggestions for how clinicians can address at least some of the out-of-pocket costs during and after the clinic visit. So first, I'll start with a patient story. Ms. Smith, she's basically an aggregate of many of the patients I see at my clinic, which is a safety net primary care clinic in Durham. The majority of the patients that I see are low income, enrolled in Medicare plus minus Medicaid, and have difficulty getting access to at least some basic necessities like healthy food and transportation. Ms. Smith is 62. She works as a home health aide in Durham, and she has employer-based insurance, but it's not very generous. So she often has high copays for various aspects of her care. She has a history of diabetes, heart failure, and hypertension, and she takes 8 medications a day. Her diabetes isn't very well controlled, and so I'm trying to be a good doctor for her, and I tell her I'd like to prescribe her an SGLT2 inhibitor called dapagliflozin. And I tell her that SGLT2 inhibitors are highly effective. They're a relatively new drug that improve outcomes for diabetes, heart failure, and kidney disease. And basically, I just, talk about dapagliflozin being the most amazing thing there is. But she stops me and she says, okay, doc, but how much will it cost me when I go pick it up at the pharmacy? And it turns out that Ms. Smith has been having trouble affording her medications, and she isn't alone. About a quarter of adults who are enrolled in private insurance or Medicare specifically report having trouble affording at least some of their medications. This number rises to 35% among patients who are prescribed 4 or more medications, and 58% among patients who spend $100 or more per month on their prescription drugs. Patients aged 50 to 64 are also more likely to report struggling to pay for their medications compared to older patients, maybe because they're more likely to be underinsured on private insurance, like a bad private insurance plan. Patients like Ms. Smith, who aren't yet eligible for Medicare and have 3 or more chronic conditions, are highly vulnerable to the financial burdens of healthcare. And when patients with multimorbidity have trouble paying for their medications, they often don't pick them up from the pharmacy. And if they do, they might skip doses to make their prescriptions last longer. And cost-related non-adherence, as you've seen, is really common. Up to a quarter of patients greater than 50 years have admitted to it, especially when they have high insurance cost-sharing requirements, when they have more comorbidities, when they take more medications, and when their incomes are lower. Patients with multimorbidity who are younger than 65 are twice as likely to report cost-related non-adherence compared to older patients. And when patients don't take their medications as prescribed, not surprisingly, their illnesses progress, negatively impacting their quality of life and increasing the risk of age-related cognitive and functional limitations, hospitalization, and death. And before I move on from this kind of background portion of the talk, I thought I should at least mention here the Inflation Reduction Act that was just signed into law just a few days ago by President Biden. The main impacts that it'll have on out-of-pocket costs, there's basically four things. So first, there will be a cap on Medicare Part D out-of-pocket spending of $2,000 per year starting in 2025. So this is just drug spending, Medicare Part D. All vaccinations for people enrolled in Medicare will be free. Not all vaccinations were free previously. Think about the shingles vaccine, for example. There will be an out-of-pocket cap on insulin at $35 per month for patients enrolled in Medicare. And the premium subsidies, the higher premium subsidies that the ACA marketplace put into place during the COVID-19 pandemic will be extended for 3 more years, making private insurance more affordable for a lot of people. Medicare will also be able to start negotiating the prices of 10 prescription drugs with pharmaceutical companies starting in 2026. Hopefully, lower prices for those drugs will translate into lower out-of-pocket costs for patients, but we won't see any difference for a few more years. So getting back to Ms. Smith, she tells me that she only ever learns the cost of her medications when she gets to the pharmacy. That probably sounds familiar to the clinicians who are in the room. Once she's at the pharmacy, it feels kind of too late to make changes to her management. She's often too embarrassed to call me back. And so, like many patients, she either decides to pick up the medication and forgo other necessities or just not pick it up at all. But this time she wants to get ahead of the problem. So she shows me her insurance information and she asks me, based on this, how much will I pay each month for this new drug over the course of the next year? So now I'm going to describe a study that I led showing how hard it is for clinicians to actually estimate out-of-pocket costs at the point of care. So to figure out her out-of-pocket costs, I need to be familiar with a number of insurance terms that can be quite complicated. And most of you probably know these terms, but I'm going to go through them here just in case, just so we're all on the same page. So pay attention because pop quiz coming up. So the deductible is what the patient has to pay out of pocket before any of their insurance coverage kicks in. The copay is a flat fee that the patient might have to pay when they purchase care, like a $20 copay every time they go see their primary care provider. The coinsurance involves patients paying a certain percentage of the price of an item, for example, 50% of the price of a drug. Drugs are covered according to their tier. So tier 1 is for cheaper drugs, and as drugs get more expensive, they go into higher tiers and the cost sharing for them increases. And then finally, there's the out-of-pocket maximum. Since the Affordable Care Act went into effect, every private insurance plan is required to have one. Basically, patients can't pay more than this maximum in a given year for any of their care, except for their monthly premium. Not surprisingly, patients have trouble understanding their insurance. And so similar to Ms. Smith, they often look to their doctors or PA or NP for help estimating future expenses. And to be honest, as an internal medicine resident just a few years ago, I didn't know what any of those terms meant, maybe except the copay. And so when I started training in health services research, I decided to figure out whether other doctors knew what these terms meant, or if they were just as confused as I had been as a resident. So what if we gave physicians all the drug pricing and insurance information they needed right there in clinic? Would they be able to help their patients estimate their out-of-pocket costs? And so to answer this question with my mentor, Peter Ubel, we sent an anonymous survey to a random sample of 300 primary care physicians who were either internal medicine or family medicine trained, 300 gastroenterologists, and 300 rheumatologists across the country. We excluded residents, VA physicians, IHS physicians, and any physicians who said they had retired. We collected some demographic and clinical characteristics. We gave physicians a number of statements assessing their attitudes toward cost conversations. And then we gave them a patient vignette that was intended to evaluate their understanding of basic insurance terminology. And so the image here is the vignette that we sent to primary care physicians. And no need to read it because I'll walk you through it in a lot of detail in the next slide. In the vignette, there's a hypothetical patient. She's prescribed a new drug, drug X, that costs $1,000 a month without insurance. The patient's main private insurance information is then provided, and that's what you see here. And, in this survey, clinicians who were reading the survey had as much time as they needed to study this insurance plan. We then are told that the plan runs from January to December, and the new drug that I'm about to prescribe is a tier 4 drug. There were 4 questions that asked respondents to predict how much the patient would have to pay out of pocket at various points throughout the year. And the questions were intended to capture physicians' understanding of deductibles, coinsurance, copays, and out-of-pocket maximums. So those terms that we talked about a few slides ago. All right. And so this is where the poll will come in. So I'm going to walk you through the questions so you get an idea of how difficult they are. And I'm going to ask you to try and figure out the answer to each question. We're going to try and use the poll feature on Zoom, but it's my first time doing this. So if it doesn't work well, we can abort. So the first question in this vignette asked how much the patient would pay for the drug in January. And I'm going to give you 15 seconds to answer. And then Julie, I'll ask you to just share the results. All right, let's see those
I had the
results.
same question as Janet. How much was the drug again?
The drug was $1,000. Sorry, I did not have my chat open. Like the non-insurance cost is $1,000. All right, should we look at the responses?
All right, let's see here. I'm going to try and share the results. Hopefully this works. Can you all see this?
Okay, so we have 45% who said it was $1,000, and then lower percentages of people said it was other various dollar amounts. All right, so drum roll. In January, the patient wouldn't yet have met her deductible of $2,000, and so she would have to pay the full price of the drug, which is $1,000. So you still have more chances. The second question said, now suppose she sees you again in March. Since January, she's had 1 clinic visit and taken 2 months worth of the drug, which again costs $1,000 without insurance. What will she pay out of pocket for just this drug in March? Okay, let's look at the results. All right, lots of people said 500. Strong work. So as a reminder, the drug is a tier 4 drug, and by this time she would have met her deductible by paying $1,000 for the drug in January and $1,000 in February. And so she would owe the coinsurance for tier 4 drugs, which is 50% or $500. All right, so now let's get to the third question. She also takes 3 other drugs, all tier 1. What will be the sum of her out-of-pocket costs for just those 3 drugs in March? All right, let's see the results. All right, so 10% said 0 and 70% said $60. All right, and now you were right, most of you. Her insurance plan indicates a $20 copay per tier 1 drug, and so she would owe a total of $60 for these 3 drugs. And then finally, the fourth question. Suppose it's December. Since January, Ms. Gray has taken 11 months worth of drug X. How much will she pay out of pocket for just this drug in December? All right, I know that one was a little harder, but let's see the answers. All right, 58% said 0 and 25% said 500. So the answer is that by December, she would have met her out-of-pocket maximum of $6,000. If you were able to figure that out, you probably spent some time and some mental energy actually trying to figure that out, which a lot of us don't have that kind of energy or time in clinic. But in the end, she owes nothing for the drug because she's already met her out-of-pocket maximum, and so she would pay 0. Yes, exactly. What doc has time for that? Yes, agreed. So thank you so much for participating in this poll. I hope it illustrates how difficult it can be to figure out our patients' costs in the clinic. So I asked these same questions of the doctors that I surveyed, and our response rate was 46%. So we sent the survey out to 900 physicians, got 402 responses. And after exclusions, our final sample included 369 respondents. And here are some of their characteristics. Mean years of experience was 22. The majority of respondents were white, non-Hispanic, and male. And the 3 specialties we targeted were fairly equally represented. Respondents spent the majority of their time in the outpatient setting caring for patients with Medicare or private insurance. And we conducted an exploratory factor analysis to see if physician attitudes toward cost conversations could be categorized into themes. And we ended up with 3 broad categories: duty, perceived barriers, and perceived expectations. And in this table, we see that the majority of respondents do feel a duty to initiate cost conversations with their patients. But they also acknowledge that a number of barriers get in the way. Barriers included insufficient time, insufficient knowledge about out-of-pocket costs, and discomfort with cost conversations. Despite this, almost 2/3 of respondents did think that their patients expected them to solve their cost-related issues. And this finding is supported by a number of previous studies that have found that while a median of 84% of patients and 78% of physicians want to talk about costs during clinic visits, they only do so about 1/4 to 50% of the time. Patient and physician reported barriers in these previous studies were similar to the ones we found in our study. The mean percentage of vignette questions answered correctly was 58%. So on average, respondents answered 2 out of the 4 questions correctly. So you can, in your mind, compare that to how you did. Only 21% of respondents answered all 4 questions correctly. And I just want to point out that you all as a group did a lot better than the doctors that we surveyed in this study. And I would like to give credit to my little tutorial, but you may just be a lot more attuned to what out-of-pocket costs are and how insurance works for your patients. So when we looked at responses separately by vignette question, we found that fewer than 2/3 of physicians demonstrated a clear understanding of any of the insurance terms we talked about. And there wasn't one question where respondents did significantly better than another. So we did a multivariable linear regression analysis. thinking that we'd find something to explain physicians' ability to answer the vignette questions correctly, but we were wrong. We thought, for example, that primary care doctors would do better because they have more experience talking through options, while subspecialists just refer their patients to financial advisors, but that was not the case. No difference between specialties. Maybe years of experience would improve performance, but that also wasn't the case. We thought doctors who saw more patients with private insurance or Medicare would do better since they have more experience taking care of people with high cost sharing requirements, but that was also no. And then finally, we really thought views on cost conversations would affect performance. So it would have made sense if doctors who thought it was their duty, for example, to discuss costs performed better, or for doctors who said that they didn't have enough time for cost conversations to perform worse. But attitudes didn't really predict performance. So what we were left concluding is that physicians consistently have trouble understanding basic insurance terminology, regardless of a number of demographic, clinical, and attitudinal characteristics. And actually, in our regression, there was one characteristic that we did find to be associated with performance, and that was access to cost or coverage information in the electronic health record. So here you see that access to cost information in the EHR was associated with an 11% increase in performance on the vignette. And this is a promising finding. It suggests that when cost or coverage information is available in the EHR, doctors may become more aware of their patients' out-of-pocket costs. But the results should be interpreted with caution given the number of covariates I included in the model and the variability in the type of cost information that different EHRs provide. So to recap the study, the objective was to assess whether physicians understand their patients' insurance plans enough to accurately estimate their out-of-pocket costs. And our results suggest that while most physicians think it's their job to talk about costs with their patients, they're unable to accurately estimate the costs, even when they have unlimited time and all of the necessary information at their fingertips. Our findings shouldn't be surprising. Healthcare accounting isn't part of our medical school curriculum, and even if it were, we would still find it hard to keep up with ever-changing cost-sharing strategies that insurance plans implement. So as a result, when cost conversations do occur, they're often unproductive or may even be counterproductive. Like, for example, if a physician provides inaccurate information regarding the cost of a medical service. So the bottom line is we need help navigating our patients' out-of-pocket costs. We found in other work that clinicians are frustrated by the lack of out-of-pocket cost transparency. So in a separate study that we conducted where we gathered clinician focus groups at Duke and the University of Pennsylvania, we talked to neurologists, rheumatologists, primary care doctors, and oncologists and asked them to recall prior cost conversations that they had had and describe to us the barriers that they had met to effective cost conversations. And we also asked them to brainstorm strategies that they or their clinic could use to facilitate cost conversations. And so I'll just read you a few illustrative quotes. The easiest strategy is just try prescribing something else. Have the patient go back to the pharmacy, see how much that one costs, and then call us back. Like, that is the most backwards 1970s era technology strategy that you can even imagine. But that's what you have to do to figure out whether it's covered or not. Another quote, I feel that in some ways it is my responsibility to anticipate costs, but I also resent having to spend the time that it takes to call the pharmacy back or get the alternatives. And one clinician said they have a package for Epic that would allow you to import this data in real time. So when you prescribe a medication, you can have that conversation with a patient to say, this is going to be your out-of-pocket cost, or I can't believe that's your out-of-pocket cost. Let's think of something comparable. And I found this last quote very interesting. And it seems so obvious. Why not just make patients' out-of-pocket costs available at the point of care when both patient and clinician are present and able to make a decision together about the best course of action, taking into account both clinical and financial considerations? So now let me briefly describe new efforts at the federal level to improve out-of-pocket cost transparency for patients. Starting in January 2021, CMS, the Centers for Medicare and Medicaid Services, began requiring that Medicare Part D drug plans make out-of-pocket costs for medications available to clinicians at the point of prescribing. Large electronic health record companies like Epic and Cerner now offer tools that communicate directly with insurance plans behind the scenes to determine the out-of-pocket cost of a medication at the time that it's ordered. And these are called real-time benefit checks or real-time benefit tools. I'll just, for consistency purposes, call it RTBC from now on. And CMS requires that Medicare Part D drug plans cooperate with these tools and make out-of-pocket costs available to prescribers. It's not mandatory for clinicians to use them, and it's not mandatory for privately insured patients to have access to them, but at least it's a start. At least these things exist. And I'm going to show you, so Duke has this tool. We've had it for about a year now. And so I'm going to show you what the workflow looks like. I don't know if Northwestern has this yet. So in my view of Epic, I, at the bottom of my screen, can click to add an order if I want to order a medication. When I click on add an order, there's a little open box and I can type in a medication. And so if we think back to Ms. Smith from the beginning of the talk, I'll type in dapagliflozin. And now I have two choices. Either I can sign the order without looking up the out-of-pocket cost, and the order will be sent directly to the pharmacy and my patient will find out the cost at the pharmacy. Or I can click on that little estimate button, which is very tiny. And if I click on it, I'm basically asking this RTBC to estimate the out-of-pocket cost of the drug. What happens is the RTBC sends a fake claim to the insurance company or the pharmacy benefit manager and spits out the out-of-pocket cost estimate and any lower cost alternatives in the same therapeutic class. So in this case, when I did this for a real life patient, empagliflozin came back much less expensive than dapagliflozin, and so I switched to empagliflozin. And in this case, my patient is going to be saving over $1,000 a year with just that couple of clicks. So a tool like this has a lot of promise. You know, it can provide patients with the actual out-of-pocket costs of the medications they're prescribed. It can allow clinicians to bring up the financial trade-offs of any new treatments. And it can potentially help patients get access to evidence-based medications that are actually affordable. Like in the example above, dapagliflozin may not be affordable, but empagliflozin may be within reach. And obviously the tool isn't perfect. As it is, it only provides drug costs, and it doesn't work for Medicaid. So I don't know what medications are on the Medicaid formulary, at least in North Carolina. And it doesn't work for uninsured patients. So I still have to go on a GoodRx app or some other kind of drug cost aggregator to find out the cost of drugs for uninsured patients. But still, better than nothing. And now the question is, does this tool improve access and or improve outcomes for patients? And so far, one study has shown possibly higher fill rates among patients whose doctors use the tool, but more work needs to be done. Not a lot of doctors use these tools yet. And in general, we just kind of don't know what's going on with these tools. It's unknown whether and how frequently primary care providers use price transparency tools for their patients, whether they preferentially use them for some patients over others, how acceptable the tools are for primary care providers with complex multimorbid patients, and whether out-of-pocket price transparency at the point of prescribing affects clinical outcomes, including disease control and medication adherence. So moving forward,
Carolyn, can I ask you a quick question?
Yeah, go ahead.
No, the RTBC, that's awesome. We've done some work when we try to automate certain functions because, you know, adding another click into the workflow seems to have a low yield. Is there even the possibility of that auto-generating a price comparison?
There is. So you can, on the back end, like your Epic people, I don't know what their actual title is, but the Epic people can, there's lots of different features you can pick for this tool. And one of the features you can pick is for the cost to pop up automatically. And you can decide, like, if the cost of the drug is going to be more than $20 or $50, it should pop up and give me alternatives. The Duke people decided not to do that because they're worried about alert fatigue.
Mm.
But I'm working with another institution, University of Colorado, and they have decided to do a pop-up. I think if the drug is $50 or more. So yeah, that's stuff that you can kind of play with and see what works best. But I agree, and the estimate button is so tiny that I think people just forget.
And just one follow-up on that. So do you have any data from Epic at Duke that shows how often, can you actually look to see, like in the back end, how often they click on it?
I have just extracted those data and I'm about to look at them after
great.
they are clean. So I will let you know.
All right, thank you. Sorry, thank you.
No, but that's exactly what I would like to do. Just, no one's used these tools before. And so we need to just look at the basics, who's even just clicking on this thing. So I'm going to describe just really quickly the kind of overview of a K-23 that will hopefully get funded in a few months. And I'm hoping to evaluate use of this tool by primary care providers for patients with multimorbidity. And the reason I chose these two groups is patients who have multimorbidity are at particularly high risk of suffering from high health-related financial burden and cost-related non-adherence. And they often get excluded from studies because of their complexity. And then primary care providers, up to 70% of our patients are patients with multimorbidity. So it kind of makes sense to look at those two groups. Yeah, I see there's a question.
Well, yeah, at some point I'll figure out how to lower my hand. There it is. So I'm actually working on a project on improving single pill or fixed dose combination for hypertension. And so that's like another layer, because if we go back to your example, how many drugs is this person on? And so it could be different from any of the research. Certainly this also involves cost transparency, because physicians will keep prescribing the diuretic and the ACE inhibitor or the ARB or whatever it is. But I'm also wondering, is there anything within this or in your work that once you sort of improve price transparency, then how do you also improve, oh, wait, those 5 drugs could be one?
Like not deprescribing, but simplifying the medication regimen.
Right. And so if you're really about, if we know transparency improves adherence because I'm going to fill it, there is also that thing, especially as we get older, we are, you as my doctors tend to keep throwing more meds at me. But as more and more evidence comes out that there's all these combo drugs. But as I said, it could not be today's call, but I'm just throwing that in everybody else's head who's still practicing medicine. That's another layer.
That's really interesting because, so I'm realizing as I start studying this tool, it's kind of dumb. So, I mean, it's great that we can get the costs, but it can't do anything complicated. All it can do is tell me what are some less expensive alternatives in the same exact therapeutic class. If it were smarter, if it could be made smarter, then it could look, oh, what other medications is this patient on? And have you thought about also this less expensive alternative that also would reduce the medication burden because it would get rid of the lisinopril in addition to the CTZ or whatever. Yeah, that's a really good idea, but it's currently too dumb for that.
Okay.
And we're going to have to show that putting the money into making the algorithm smarter saves money somewhere.
True.
Yes.
I'm wondering, the AMA has an incubator 24/7. I may have to go to my bosses and see if that's something we want to throw into the incubator.
I did try to get my institution to fund a study looking at this tool, but I think it's not in the institution's interest really. So we do, I haven't really thought about how use of this tool could save money for the health system that we work for.
Yeah. Well, it could adherence, better adherence means no ER visits or out of the hospital, but that's a long-term study.
Yeah, exactly.
Right. Well, sorry to derail you.
No, that's okay. It's a good segue because I'll show you what I actually am going to ask in this Kay, that I don't want to jinx, but hopefully we'll get. So this is just kind of the framework that I'm using to think about the tool, to try to evaluate how it's being used and what its impact is. And so on the left, you can see that the primary care provider has the option to use the tool to estimate a medication's cost before prescribing it. But the decision depends on her own characteristics, her patient's characteristics, and the visit characteristics. So you can imagine, for example, that a clinician might not use the tool as often as she should for patients with more comorbidities, because those visits are already complicated, or a patient with impaired cognition. I'd also like to evaluate the tool itself. And we talked about this a little bit, how usable is it? Is it better for it to pop up or for us to have to click on the little estimate button? Is it conducive to productive cost conversations? Or do clinicians just kind of switch the medication based on their assumptions about their patient in front of them? And do clinicians like having it there, or is it just one more annoying pop-up and they wish it would just go away? And then finally, once the primary care provider clicks on the tool, finds out the price of the drug, and prescribes the lowest cost alternative, do patients end up paying less at the pharmacy? Does their long-term adherence improve? And what about disease control and progression? So just to wrap up, in the meantime, while we wait for medication out-of-pocket price transparency tools to become more available and to improve, I just wanted to describe to you the ways that we can help lower other costs for our multimorbid patients. So in this next portion of the talk, I'm going to describe how we can screen our patients for financial stressors and address at least some of their health-related financial burdens. So first, clinics can incorporate questions about cost in pre-visit screening questionnaires. In qualitative studies, clinicians and other clinic staff have suggested screening patients for financial hardship at intake. It doesn't even need to involve the doctor. Staff checking in the patient, the medical assistant, the nurse can do this. For example, in our qualitative study that I described earlier, one person said, what about having a checklist that says, okay, what are the financial pain points? When do you meet your deductible? When are you most vulnerable to financial toxicity? And maybe we can try and come up with non-judgmental ways of screening patients to avoid the shame that some patients might feel about their financial difficulties. So asking things like, how much can you afford to spend on your healthcare per month? Or what's your healthcare budget per month? And the questionnaire could even clarify whom patients feel most comfortable speaking to, clinicians or ancillary staff. Another strategy would be to systematically screen all of our patients for health-related financial hardship during the clinic visit, not just the patients who we think might be having trouble. In study after study, physicians report initiating cost of care conversations only when they sense that their patients are having difficulties. We rely on clues like direct mention of financial struggles, poor adherence, clinic no-shows, a greater number of chronic conditions. A recent review actually found that physicians are more likely to engage in cost conversations with patients who are younger and white, raising concern that there's also a lot of implicit biases playing a role here too. So with the rising cost of medications and medical devices, we should probably assume that every patient in front of us is at risk of health-related financial hardship, regardless of their appearance, their medical problems, or their insurance. Another strategy we can use is to try and anticipate as many costs as we can. Even though it's really difficult to anticipate out-of-pocket costs related to drugs, medical devices, and lab tests, many costs can be anticipated, mainly indirect costs. So in one study from a couple of years ago, a prenatal clinic met with success when they provided new patients with handouts that they could fill out on their own. The handout included items like transportation, childcare, food expenses, time off work, parking, and medical copays. And patients could kind of think ahead over the 9 months of my pregnancy, what are all my costs going to be? And in our qualitative interview of clinicians, some reported that their clinics had developed lists of laboratories and diagnostic centers with the lowest prices in their areas. And they would use this list when deciding where to send their patients for tests and medications. And fourth, we can learn how to have productive cost conversations. As physicians have more of these conversations, they can get better at them. And one person in our study suggested giving a script to all clinicians, similar to a script she had recently received for another topic. She said, I think it would be helpful if we were given scripting. There was an end-of-life serious illness conversation that I think it was Duke enrolled. And I found that really helpful, that there was this scripted language that was vetted as valuable. And it would help me if there was some language that we had to talk about these issues with patients. And actually, America's Essential Hospitals and the American College of Physicians make some of these types of tools and scripts available on their websites. So I'm going to show you a couple of examples. Here, the ACP gives some examples of how you can set up the conversation and make the patient feel comfortable. So this first quote, our goal is for you to get the best care with fewer problems and lower costs. This may involve us asking new types of questions. And you can ally with your patient and show that you're trying to implement patient-centered care. Our goal is for you to get the best available care, for example. They give examples of how to normalize the conversation. So up here, other patients I've worked with have dealt with the financial stress of healthcare in a variety of ways, including cutting back on medicines, canceling appointments with doctors, and cutting back on home expenses. Have you made any of these changes due to financial stresses from your health? And the ACP recognizes that clinicians often don't start cost conversations because they worry they won't know how to answer their patients' questions or won't know how to fix the problem. And so here they provide scripts for how to answer some common questions and how to set up next steps at the end of the visit. So here, for example, would it be helpful to talk to someone else on my team about your options? And that way you don't have to invent stuff and say things that might end up being wrong. You can just say that there are other people in the clinic who may be able to help. And cost conversations are hard, especially given the logistical and informational barriers that exist that I've talked about today. But at least showing our patients that we know costs are an issue can move us closer to care that's as patient-centered as possible. And finally, what about incorporating costs in deprescribing decisions? This may be a little bit controversial, but I'll go ahead and talk about it anyway. We think about deprescribing as discontinuing or reducing the dose of medications for which risks outweigh benefits, drugs that aren't needed anymore or that are inconsistent with goals of care. We usually think about harmful drug side effects, drug-drug interactions, and drug-disease interactions, but we don't usually incorporate costs. And what if we did? Incorporating costs in deprescribing decisions could have some benefits by acknowledging that medications can have medical and financial harms and benefits. We're making deprescribing decisions more patient-centered and potentially increasing trust in and satisfaction with the patient-clinician interaction. There's also often a lot of uncertainty about a medication's benefit versus harms among older and chronically ill patients, since they're often excluded from clinical trials. And so in these cases, considering out-of-pocket costs could help tip the scale towards deprescribing for some of our patients. And then finally, removing a very expensive drug from the medication list could make the remainder of the medication list more affordable and make adherence to those remaining drugs a lot better. So with that, I will end those suggestions and stop here. And thanks so much for taking the time to listen. And I'd love to hear any questions or comments.
Thank you so much. That was a great talk, and obviously really such an important topic for our patients. I think you got a lot of response from the audience, as you did from your survey, since so many people feel strongly about this. So first, I'll just open it up to the group. Is there any questions or comments? Feel free to unmute or raise your hand, whenever you feel comfortable. But really, really great talk. A lot of great ideas. No, I don't see
That
any.
was really well done. Thank you so much.
Yeah, thanks. Thanks for your participation.
Yeah. And I think Mike had to take his son back to college, but he also said in the chat, fantastic talk. So thank you.
Yeah, thank you so much.
Any other questions or comments?
I had a question, and I apologize if you addressed this, but I was managing a patient at the same time. Did you talk at all about the role of having a PharmD as part of the clinic?
I did not, but it is something I've thought about. Not every clinic has a pharmacist, but mine does, and I often go to her for help with cost issues. And so what I've wondered is, since we all know that adding an extra cost conversation and adding use of this tool to the clinic visit would just take extra time and be really annoying, maybe it's something that we could have the pharmacist do instead. So it's something I want to explore in my upcoming grant. Just talk to the clinicians and ask them if they'd feel comfortable with that, and potentially interview pharmacists as well.
Thank you.
It's a great point. Other questions? All right, well, thank you everyone for joining today, and thank you again, Dr. Sloan, for your great talk.
Thank you so much.
Thank
Thanks
you.
everyone, we'll see you next month.